Thanks a lot, Regina. Dzień dobry. Dzień dobry. Oh, that's my Polish. Sorry. Okay, so I'm very happy to be here and to support this very exciting development of community mental health in your country, which is growing very fast, and it's in a way bottom-up process that is also impacting at the government level, which is quite unique in these days. In many other, not in so many other countries, is happening the same. So I will talk mostly about international trends in community mental health. Of course, I will also refer to what Lydia said before about the institutionalization. I will try to present my own perspective on that based on my experience in Trieste. Well, I started to work I was immersed, full immersion into an elderly infirmary ward of the psychiatric hospital, where the lost of the lost ones were anyway relegated at the end of the transformation process. They were the so-called, hard to say, human residuals of this process, and all the people there, all the staff, including the director, has very little expectations of these people. But with a group of volunteers, I was just a precarious doctor at the time, was hired there, but we were able anyway to move a group of nurses, very traditional ones, to create a great transformation. And most of these people in the ward, 30 people, were able to be discharged. The wall was closed in 2 months' work, very intensive work, and they were relocated in group homes and other places, including those with severe forms of regression from psychosis or dementia or mental handicap, etc. It was a wide composition of the clients there, and it was very exciting to see that and to see how the process of rehabilitation included the staff that were, enhanced in their function to support the clients in this move from the institution to the community. So community mental health, in a way, it's an approach which is concerned with the mental health of the population, not just of the individuals, and it's the new scene that it opens when you move from the institution to community. So it's rooted in those communities, in the resource of a community, in the social relationship of a community, and offer treatments that are, in a way, carried out in the context of life using those resources. And they, of course, as we heard from Lydia, includes promotion, mental health promotion, prevention, and also community development, which is a very important component. You cannot just put physically people into a community if you don't engage the community to make a change in attitudes, in a way, all the opinions about mental health and relationship toward those who are considered to be not to be integrated in the past. So the Italian way, I think it's important to reflect, because it's now 44 years from the Italian reform, from the Italian reform law of 78, which is still the national law for health, and it includes a component of mental health. It's in a way still a model of reform, even if this didn't work perfectly. It took more than 20 years to be achieved, finally. But it derives directly from the process of deinstitutionalization, not just by eliminating the asylums, but changing the philosophy of the intervention, the values which are connected to that change, and the social role of the mental health services, not anymore by controlling people, deviant behaviors, but integrating diversity into the society. So it was pioneered by a movement that started from the professionals. This is clear to be said. At that time, a group of directors and psychiatrists working in psychiatric hospitals refused to go on and to work in those kind of institutions. They wondered themselves about what was their role in therapeutics. So what was their role in care and in treatment? How they can treat people in an institution that was based on social exclusion of the clients. The Law 180 that resulted from this movement was the first act worldwide to abolish the psychiatric hospital and mostly give back the full rights of citizenship, the condition of citizenship, a status to mental health clients. So they are citizens like the others. This was completed, as I said, in 2 decades. So there were a lot of fights and slowered attempts to slower the development by politicians, but also by professionals. There were contradictions between the professionals, refusal of the reform. So it was anything that is related to humanity that happened in those 20 years. But then it was achieved also through a very clear mandate, top-down in the last 5 years, to produce plans to overcome the residual of psychiatric hospitals. And this was achieved in 1999. After many years, also the forensic hospitals started the process of closure. These were very backward institutions, and these were closed in 2018 after 4 years, now replaced by small 20 beds units, which are regionally based and connected to the mental health departments. So we can talk about the first wave of deinstitutionalization from 100,000 inpatients in psychiatric hospitals in Italy, a very wide number. There were still 48,000 patients when the law was enforced, so half of the work was done before the law. This demonstrates that even if you don't have such a progressive politics, you can do it anyway. You can do actions to work within institutions and change those institutions. Then the psychiatric hospitals were changed, were closed by the law, which forbid the psychiatric hospital new admissions to psychiatric hospitals, the constructions of new hospitals, and set up community-based care. It's called extra-hospital care at that time to be the rule, and voluntary treatment to be the rule. So the limitation of involuntary care to 1 week, or this can be prolonged, but just an act that doesn't suspend your citizenship rights, but just altering your condition because someone takes some decision on your health. This can be still debatable according to the CRPD, the Convention on Rights of Persons with Disability, but at that time it was a great advancement from the previous condition where people can be quickly interned for their life after 28 days. If they were not discharged from psychiatric hospital in Italy, they could be submitted to a so-called definite hospitalization. And only the director could, or the family, could save people from this kind of total social exclusion. So the second way was as I said, with forensic hospitals. I forgot to mention, in the law, there was no police or justice involved, so it's not the judge that decides that you must submit it to involuntary treatment, but it's the mayor that is the representative of the community and responsible for community health and well-being and social integration. It is the mayor that accepts the proposal of 2 psychiatrists. One must be of the public service. So this shifts from social order toward, anyway, an administrative act, which is not so impacting on persons' lives and social condition. So this second wave ended a few years ago, but we have current problems in Italy, so I don't have to hide them because we have weakened community mental health services at the moment, loss of staff, the budget, which is not sufficient for have a comprehensive set of services in all the country, which was still low in a few years ago, 3.6, 3.5% of national health expenditures. Now is calculated after COVID to be 2.75. In 3 years, we lost more money for that, which was the reverse that was expected with the strengthening of mental health and health services in the community that the COVID enhanced to be one of the priority. And most of money in Italy is spent in residential facilities, even in the community, group homes. Some are big group homes, no more than 20 beds anyway, but some of them, most of them, let's say, they are not really progressing, helping people to progress toward recovery. They are institutional locations where people are stuck in care. They are, they live in places which are not their homes, and so that's not a proper final outcome for a process of rehabilitation and recovery. So there is a lot of work to do still in Italy. Mental health departments are the new organization. I underline here, I point out the importance of having an overall possibility of coordinating services in a given community. In a city, basically 300,000 inhabitants is the average in Italy, so maybe the half or the whole of Wrocław, for instance, can be a mental health department that includes all the services operating in the area. This was easier, as in Wrocław, if you start from a psychiatric hospital, which is rooted in a community, and this has been transformed into a whole network of new services, and this maybe can be possible here. This in Italy encompasses a number of components, small, let's say, small general hospital units with no more than 15 beds, 1 per 10,000 inhabitants, that's the ratio of the beds. Community mental health centers, which are considered to be the most important component of this mental health department. They are open up to 12 hours a day, sometimes 24 hours, like in our region, in Trieste. 1 per 80,000 is the national average population. And group homes, as I said, with a wide range of support, up to 24 hours, but not necessarily 24 hours staffed, and day center. But the use of day center has been criticized because they can become forms of keeping people, again, stuck in care. They go every day to the day center, they do routine activities, they don't really progress toward rehabilitation and recovery. They are not really reintegrated into the community. So, as Lydia said, for the WHO guidelines, the decisive step in process of phasing out psychiatric hospital was to stop the admission of new psychiatric cases to psychiatric hospitals and creating a network of totally alternative services. I underline here a total alternative to psychiatric hospital. That's very important. It's a challenge. It's a challenge, but this is the progression. You have to look at community services which are substituting all the functions and change the social mandate of those old institutions into a new form of supporting people in the community. It was supported by many WHO documents, for instance, the optimal mix of services in 2011, where the psychiatric hospital is written that must be overcome, and with the simultaneous process of reconversion of the resources. That's another important point. To reconvert the resources spent, which are the majority for mental health in psychiatric hospital, into the new services. And it's a simultaneous process. It's an ongoing process of reducing the weight of the hospital component and empowering and enhancing the capacity of mental health services. And it must be a top-down process, because the political leaders and decision makers are important, the directors of the hospital, as well as a bottom-up process that involves all the actors. When I say actors, I mean staff, but not only staff, also the clients, the families, the community resources, etc. the unique aspect of Italy and some other few countries, all this process started within the total institution, within the psychiatric hospitals, while in other countries this was a parallel process of setting up new services in the community. Let's say the richest country, for instance, the Northern European countries, they developed community services alongside institutions. Then institutions were reduced. But in this process, let me say that there is some lackness of opportunity, because you must also reconvert not just the institution and the structure of the services, but the mindset, the attitude. So it's important that those who work within institutions don't simply transfer their practice to community, but they have undertaken a process of overall change. So another very important point it's one of the mistakes done in Italy, we started by implementing the general hospital wards, and not much emphasis was put on community mental health centers from the beginning. They came as a second choice anyway, and this is not good, because anyway you can substitute psychiatric traditional care with the medicalization of mental illness within general medicine. This is what not is expected by a comprehensive approach, which is biopsychosocial and cultural oriented, which is the modern way to look at this. So having multidisciplinary teams working and multidimensional approach to mental health. So another important point, new services must take the overall responsibility for that community, not just toward the individual patients, the individual user of the service, but with the community where they offer these services. So are really rooted in this community, and they are responsible for what happens in this community about mental health. If a person is chronified or goes to a social drift or become homeless, this is a problem of the local service, of the community service. It's not something that you can just forget and say someone else will think about, but it's your own responsibility. Final, maybe, definition, it's the simple one to be understood for lay people. It's deinstitutionalization is not just downsizing or suppressing psychiatric hospital, but removing the ideology and power of the institution, putting the person over the institution, not the reverse. So the person is not anymore submitted to psychiatric treatment and institution, but is the subjectivity, the individual value, the citizenship, the needs of this person, the life story, the social capital attached to the individual is the most important point, and services in the community must support the fulfillment of this individual in the community. That's the ideal goal, but it's not easy, and it's important that recovery processes and social integration are connected with the shift in power. So you must, what Franco Basaglia, the pioneer in Italy, said, the pedagogy of power. You must teach the others to use their power. They have power. If they are clients, they have power. If they are carers, here Regina is a great example, for instance. So they have the power to influence mental health because they are the stakeholders of mental health. Okay, so it's a complex process, including movements, political level, legislation. To some extent, you must achieve a change of legislation at some stage of your process to firmly embed the changes into a new set of norms, including the social aspects. For instance, in Italy, was not just closing the hospitals, but setting up a new law for integrating social and healthcare services into a single system, or to have the social enterprise law to promote social cooperative movement, for instance, and have another set of important laws that are complementing those changes. Decentralization is a whole system change, let's say a paradigm change. It's not just conceiving a parallel system to institutions. It needs a clear mandate. It needs to have transformation plans as we are trying to do with Jan Pfeiffer in Slovenia and is doing for all his career in other countries, you must to have clear plans and setting steps for closing the institution. You have to face the resistance to change. There always are, related to the fear of the change in the professionals, but the fear changing the users and the families and the community. So it's normal to have those, and so you must work together with all these stakeholders. The process, as I said, the process of rehabilitation includes professionals. It's not just for the users. They have to change their way of working, their mindset. It must be comprehensive, whole life approach, we say. The whole life of the user is a problem for this new welfare that is built around the change of mental health. What change are for users? So having human rights achieved, as Lady underlined before, realizing citizenship also in terms of participation to their community. They are active members. If they work in a social cooperative, they can contribute to with their work to, for instance, establishing a new company, providing services for all the customers, let's say running a restaurant, for instance, for the population, etc. Autonomy and responsibility are key to social recovery. They can be achieved by personal planning. It's very important with the person. Start to have a prospect of the future, working with the person and setting up clear goals, what they want to achieve from their life. It's very important for all of us. And social and healthcare come together, as we heard. So it's a whole change of the system. It's change of the interpretation of the illness. Usually psychiatry, even with the best intention, can conceal human experience of suffering, of a person suffering. And decentralization is a strategy to overturn all this sort of oppression and mobilize resources. We are now moving quickly to the issue of community services. It's very strange, I have to say, being in this field for about 45 years almost, that there is not a standardization of the best examples of community services. There is no science around community mental health. It's just still a very empirical attempt. Even, for instance, organizations like OECD has set up a number of principles. They are, what we heard, focus on the individual with the experience to mental health issues, having accessible services, high quality, integrated, multi-sectorial approach with social care, for instance, prevention and promotion, with the strong leadership, as we heard, and good governance, and being innovative. But these are very vague, and there is indicators, performance indicators, and for OECD, the WHO has set up interesting indicators in the Comprehensive Mental Health Action Plan, which is a great document written a few years ago, but is still prospecting toward 2030. It's a great document that I recommend to read. But the problem is, for instance, there are a lot of confusion about a number of issues. One is, what is important, being a good therapist or having a good service around? Let me say the second one. So it's not about just the content of care in terms of kind of treatment you can make, but also the delivery, the way you offer a service, the overall impact of an individual experiencing mental health care. The clients must have a, sort of a route through our services, and it must be preserved as a person. It cannot be destroyed as a person by, for instance, a bad experience in a ward, with restraint, and then he can go to a good psychotherapist. This doesn't mean anything. So it's an overall experience to be conceived. So working on all the aspects of the process of care, not just on single techniques, and integrating, again, and co-producing services with the stakeholders. Another point, we don't have to conceive, as in Italy, another mistake we did, structures with a function separated from the other structures and services with another function. So the acute service that takes care of the emergency in acute phase. Then you have the ongoing care in the community mental health center. Then you have rehabilitation places. But all these functions mean crisis care, ongoing care, rehabilitation. They are embedded in the same services. They must be a continuous process. Rehabilitation must start from the beginning, for instance, not just when you are a chronic patient and you have a special service to take care of rehabilitation. Rehabilitation is a function of crisis approach, for instance, very early rehabilitation, etc. And so each structure overlaps with the other. For the acute ward, for instance, must start to think in a community vision, and the community service must wonder what is happening in the acute ward, for instance, and the daycare center, etc., etc. This function overlaps. Specialization is important. Now the fashion is to have early intervention services for everything. It's correct. For crisis, for early presentation of psychosis in young people, for eating disorders, for dementia, for all this require early intervention. But you can't have specialized services if you don't set up a comprehensive infrastructure of services. In southern Italy, I know in my original hometown in Bari, they have a good program for young people, but there is no program for all the adult mental health care. So what does it mean? So it doesn't mean anything to have a focus on young people if you don't have a system behind that. So that's another kind, because the risk is fragmentation of services in the community. You have separated programs but not an overall organization. So it's not a sum of intervention, it can be a vertical synergy of concurring services to the same aim of providing a balanced system of territorial responses. So we say organization based on principles, they must be respond to clear values, human rights, for instance, or recovery, the center aspect of the person, the center of care, etc. They must provide empowerment of people treated by the services and their carers. They must be considered. They have a say everywhere at any aspect of the service. They must be multi-sectorial, so connected to other sectors, etc. Not just evidence-based. Let me tell this to psychiatrists, my colleague psychiatrists. Evidence-based is important, but must be connected to, yes, I know, thank you, to the ethics of care, ethical aspects of care, so let's say rights, and also to the practical experience of people. So the 3E that Thornycroft and Tansel underline are very important. Experience, ethics, and evidence, they have to come together. And someone says evidence is not the most important one. Unfortunately, it's a medical specialty, but not just a medical specialty. So there must be considered alternatives to coercion, reduce coercion as the quality rights approach. This must occur in everyday practice. It's mostly based not just learning de-escalation, for instance, of facing with a challenging behavior of someone, acting out, etc. But it's about the ethos, the overall attitude of a service that are welcoming people with open doors, for instance, is very important, much more important, again, than a single technique to be approached, to be learned. So involuntary treatment in Italy is reduced, as we said. The 24-hour service for us is important because they can provide in this way a full alternative to the traditional hospital treatment. That means having mobile teams, sometimes working 24 hours, or having beds in the community mental health center, as you choose also in, for instance, here in Wieliczka, I've seen a service similar to ours in Trieste, having beds to host people as guests during the crisis, not just as an inpatient in a ward, because they can move everywhere. They can welcome their parents, their relatives, their parents. They can welcome their friends. They can move in and out, be accompanied, not being secluded during a crisis, etc. So the domestic aspect is important for care and providing 24-hour comprehensive service, mainstreamed in healthcare organization. That's another point, because in Italy we connected mental health center to healthcare districts that provides community medicine. There are a number of examples in European countries. I leave this presentation to you because I try to connect also a number of experiences in Europe. There is no time to go through this, but there are different ways of providing community mental health care in several countries, and there are countries which are progressing toward the better mental health care. Some are regressing, so it's still an issue to have an overall international impact on these things. So Trieste is our place. All these systems are, related to clear principles of and the clear aspect of the centrality of the community mental health center. Let me go to the final. The hospitalization and hospitality, I said that. It's a place where we can say freedom first. No? Freedom is therapeutic was the old slogan. Now we can say freedom first. So don't forget, freedom is one of probably the most important aspect of human life. So you must ensure services with respect of rights, with respect of freedom of the individuals. Then the individual can be someone where you can talk to, you can talk with, speak with, and you can respect, because he or she is the main asset for care. The main resource for care. This is what we learned from our experience, and this is what we learned from the recovery process and the recovery movement worldwide. Thank you very much.